So moving on to our second topic for today, choosing third-line TKI therapy. And I'm very pleased to introduce our regional expert for this topic, Dr. Virginia Abello Polo from Colombia. She's a great physician and researcher, an ICMLF key discussion alumni, and a member of the Foundation's Latin America steering group. Welcome, Virginia. And last time Virginia was a speaker in this forum, she was on the opposite side of a TFR debate from her partner today, which was a great, wonderful discussion, which I'm sure lots of you will remember. Of course, we're talking about Professor Tim Hughes from Australia, who we're delighted to welcome back to the discussion group. Tim is another giant in the CML field. He's known across the globe as a great physician and a great scientist. Along with Professor John Goldman, Professor Jorge Cortez, and Nicola Evans, our chief executive, Tim was a founding member of the International CML Foundation and chair of the foundation until recently. Tim, it's an honor to have you here again. So I will stop sharing my slides and invite Virginia to get her slides up. And as she's doing so, I'll let the audience know that Virginia and Tim will run their session very similarly to the first one. And also we have another case which has been submitted to us from Dr. Felipe López, a hematology resident from Chile. And we will try to get his case in at the end after Virginia. Virginia, you are ready to go. Thank you.
Thank you so much for the invitation, and it's a pleasure being here again. And we're going to talk about this patient. She's a 557-year-old woman. She has only depression, anxiety, and hypothyroidism as in her history. She's diagnosed with chronic phase CML, high risk SoCal. So we start her on in Nilotinib 300 BID, and the goal for these women was to we talked about a lot about this, and she was very anxious, and she wanted to get out of the TKI as quick as she can. So she was young and healthy, and we want to go. Our goal was take her to TFR. She had a perfectly good response at 1 month, and then she started doing a regular adherence because she started reading and she got anxious and she didn't take her meds. So we talked with her again, and anyways, it was obvious for me that she had bad adherence. So at 3 months, the PCR was at 20%. So it's I was worried about that, but it's not a failure yet. We don't declare a failure at 3 months. So I would started, and it was not a good adherence. So at 6 months she had 100% adherence, and now I started worrying because she has 8% of PCR, and then but you see, as you see, the tendency is good. So we decided to start with to keep there. And then as you see, at 12 months, she's still having 2% of PCR. The adherence is good. We rule out mutations, T355I mutation. We don't have NGS here for looking for mutations, so that's what we have. So at 12 months, as we can see, she's categorized as a failure, even if the PCR is going down. So we decide to go to Bosutinib. And then she had no major toxicities, no mutations. And again, at 18 months, she has 5% of PCR. So now we have two lines of treatment. We don't have asciminib in Colombia, and it's not easy to give ponatinib in second line. We have it approved for third line only. So the challenge topics to discuss in these patients is, well, first, is the kinetic of response versus the goal of TFR. Should we keep waiting, or should we be, how aggressive are you? Would you change at 6 months? Do you wait more? Or because sometimes we want to know If the clinical response is good, we wait. Mutation analysis, we don't have another, we don't have anything else than this mutation, but if we had it, do you think NGS will help at this point to decide something? With failure at 2 lines, when we keep thinking about transplant at this point, do you think about that? And or where do you think about transplant? Because now we have so many TKIs that we tend to wait. And in the 3rd line also, we don't have asciminib in Colombia. I think we don't have any in most Latin American countries. So if you have asciminib available, how will you select in this point between asciminib and Pona? And what about if you start with Pona, because that's what we do, what dose do you start? Do you use the optic approach? Or that's my key points for this. I know a lot of questions.
They're great questions, Virginia. We might start with Mike first, please.
With Tim?
Tim.
I think,
Tim. Yeah.
can we throw the ball to Tim?
Sorry, I beg
Yeah.
your pardon.
Yeah. Okay.
Apologies.
Yeah, so really good case to discuss because not straightforward at all. I mean, at 3 months, that's a very worrying response, only 20% coming down from 80%. That's a fourfold reduction, which is not very much. So she's immediately identified as a patient of somewhat high risk. Now, you say that she wasn't taking a drug, which seems strange for somebody who was motivated. She wanted to achieve TFR, and yet she wasn't taking her drug, that doesn't seem to gel with me. I don't understand why that would be, unless there were problems with toxicity. She struggled taking it twice a day or fasting. I'd be wondering at that stage even about whether it'd be worthwhile switching it to something else, particularly because you can't do mutation screening, comprehensive mutation screening. So you don't know whether she's developed a mutation that would render her less sensitive to nilotinib. So in our own practice, we would have probably checked the PCR at 4 months. And if it was still at around that sort of level, we probably would have switched at that stage. One of the reasons we want to switch early is because if a patient's not going to respond well to TKI therapy, we want to know early, not late, because if they're not responding to any TKI therapy, we have to take them to transplant. We don't want to spend 2 or 3 years when they're at risk of blast crisis. We want to actually do it when it's clear that they need it within that first 12 months. So for that reason, we tend to be more proactive in our switching, and that's probably a little bit different from a lot of people, what they recommend, but that's just our own practice. So I probably would have switched earlier to either to bosutinib or to dasatinib. And I would have once again looked to see response. And if they still were not optimal at 6 months or 12 months, then you have this question, if you have the luxury of deciding whether they should have asciminib or ponatinib. Now, she's eligible for both because she's not particularly high risk, I don't think, from a cardiovascular point of view. So she could probably take either drug. If I was going to choose ponatinib, let's focus now on where we are now. She's now at about 2 years. She's not highly resistant. She's still at a level of about 2%. So we're not talking about completely refractory disease. We're just not getting the response we would like to get. TFR is really no longer on the agenda because patients who are at 20% at 3 months very, very rarely will get to a TFR option. So we're thinking more about just trying to control this disease to avoid the risks of transforming to blast crisis and also to avoid too much toxicity. So I think the real choice is between asciminib and ponatinib. If I were to choose ponatinib, I'd probably choose 30 milligrams based on the optic trial because 45 looked a little bit better, but it was only better for the patients who were highly resistant, that is greater than 10% BCR-ABL, or the patients who have T315I mutation, which she doesn't have. So I think going to 30 milligrams and then reducing to 15 milligrams as soon as she gets below 1% would be very appropriate. However, these are the sort of patients that quite often do respond well to asciminib. If she was greater than 10%, I would probably prefer ponatinib, but given the fact that she's somewhere around that 1 or 2%, she's not floridly resistant, I think she'd be a great candidate for asciminib. So if that was possible, I'd treat her with asciminib. If it's not possible, as you suggest, it's not available in Colombia, then I think ponatinib at the dose of probably 30 milligrams daily would be appropriate. Yes, ideally you'd want a mutation screen because there's many other mutations that might have an impact here, but not so much for ponatinib because it really covers virtually all of the mutations except the compound mutations, which are very, very difficult to treat. Asciminib is more complex. There are a number of mutations we would tend to be concerned about using asciminib. So it would be, if you had the choice, it would be very nice to have a mutation screen now before making that selection.
Mike.
I'm not sure I can really add much. That was a very thorough vetting. I'll just say I have a similar thought that Dr. Hughes mentioned about asciminib and ponatinib. In the right clinical setting, I try to choose the drug with the lowest risk and potentially high yield. So a lower transcript patient with more of a plateau or stable disease. However, the mutation testing is really helpful. In this case, going from nilotinib to bosutinib, as I recall, I mean, even if you didn't know what the mutations were, there's not a lot of overlap between those two drugs and resistance patterns. So I might, if I had to guess what you'd find this patient might be a mutation negative patient who has a plateau. Do those patients do better or worse with asciminib or ponatinib? I'm not sure we could say. I think Tim's comments about the dose of ponatinib are also important, highlighting that reduction would be the answer once someone achieved response because of the offset of toxicity. But I'd probably try asciminib if I could get it.
Mm. Anna
Well,
Inez, what would you do?
We usually are more aggressive. We feel at a disadvantage somewhat because we have to start all patients, regardless of risk, on imatinib. And the only thing that we can request for first line is different doses. So we watch them very closely at 3 months and at 6 months. And those patients who do not meet those targets fast enough, we titrate and for imatinib, and we start preparing them. And fortunately, we do have the screening for mutations through Sanger and ASO PCR T315 also mutation. We use that as a tool, but we have to move them to a second line of treatment. And depending on the risk and comorbidities of the patient, then we make a decision. It's more difficult for us to access a third line of treatment with ponatinib or asciminib because they are not covered by our health system. So you have to go to the court system to get it for the patient. And so oftentimes, when we come across a patient who has been refractory to 2 lines of treatment and is young, allo transplant, bone marrow transplant, continues to be a tool that we use. Of course, that we make a very careful decision based on the patient. And we'd like to know how the professors feel about this. We know that if you have access to more different lines of treatment with TKIs, you try to keep them on a TKI instead of transplanting them. But unfortunately, that's not the reality for us. So I'd like to hear
I
from
was
you.
going to ask the same
Yeah,
about
that's something I
transplant.
probably should have covered because that was raised as to whether this patient should go to a transplant. I mean, in our own practice, because we have, I guess, the luxury of multiple drugs, we wouldn't consider a transplant if we still had a reasonable TK option for the patient. So generally, the patients who go to transplant would be patients who have either progressed beyond chronic phase or have such complicated mutations or resistance that they didn't respond at all to any TKI. But this lady, she has some level of response. She's 2%, I think, out at this time point. So I would not consider her a good candidate for transplant. Of course, it might become an economic decision if you can't actually get hold of asciminib or ponatinib. But even switching her to dasatinib, you may well find that will maintain her in that sort of partial response level, which probably means she's got a reasonable chance of being alive and well in 10 years' time. And I think an allograft in this sort of setting of a lady of 57, I mean, I think pretty high risk, fair chance that there'll be early morbidity and certainly early mortality. So I would be very reluctant to look at transplant. And who knows, maybe you'll get asciminib or ponatinib available in a year or two, and they'll be able to switch then.
Yeah, I have a question for you, Tim or Michael. Once you get out the out of the picture, the TFR possibility for this patient, and I think about this a lot, because now when you know that at 6 months she's not doing well, she's not doing particularly bad also, but you know these patients are not going to be doing TFR. So now at that point you start thinking about what is the importance of a very deep response in these patients, and adding, changing patients early to a ponatinib that will increase her cardiovascular risk, for example, if she's doing well on that's why I was asking about the kinetics, because now, and when we have asciminib at this point for this patient in Colombia or in Latin America, it's going to be really, really expensive. So at this point, what does in this patient that is not a particularly resistant patient, do you think really having a very deep response at this point really adds to the patient to to spend all this money?
Sure. No, I don't think I'm targeting a deep response in this lady. As you say, I think the chances of achieving TFR are very low. They're not zero. We do see patients who have certainly patients who are resistant to imatinib and then go on to a second generation drug and get a good response. They've got a good chance of TFR, unlike perhaps the early impression. So, but this is a lady who's actually fairly resistant up front to nilotinib, a fairly potent drug. So I think her chances of TFR are really quite low. So no, I'm not trying to drive down to a deep response, but I think running along at, I think it's now actually 5%, isn't it? Can we look at the next slide? I think the current trend is not so encouraging.
This is the third line ponatinib already.
Oh, okay. So I think at the discussion point, it's 5%. So they're kind of creeping up, and I think that I think at that point, I think you have to worry about the possibility of progression if you can't control the disease better than that.
We have a question from the audience from Vladimir Situ to everyone, and I think Lillian, would you like to give us a better translation than I could do of that, please?
He comments that he has had many patients with hematologic toxicity, and in some of them he has gotten good results by lowering the dose instead of switching the TKI. So is there any experience in patients that you give the TKI every other day or at very low doses compared to the usual recommended dose?
Yeah, I think in hematological toxicity, you don't gain a lot generally by switching purely for the hematological toxicity, because they're all kind of got pretty similar toxicity profiles. So yes, absolutely. Sometimes you have to go to modified doses. And I think dasatinib is a good drug from that point of view because we have a lot of experience using it at 70, 50, even 20. I've had a patient who was on 20 milligrams alternate day for about 5 years because of severe thrombocytopenia and eventually achieved a response. So I agree, that can be a situation where switching isn't that effective.
And he has another question that's in cases of resistance, is it recommended to use asciminib added to another TKI
Well, we're still trying
in
to work out.
association?
We're still trying to work out the role of combination of asciminib plus one of the ATP competitive TKIs. One of the challenges was clearly with cytopenia, it wouldn't have any role at all. But in a situation of resistance, there may be situations where that would be effective. But the phase 1 study that Mike and I were so involved with, it's really hard to be convinced that there's a group that are really benefiting from the combination. I think there will be groups that'll benefit from combination, but I think at this stage we haven't really defined clearly what those groups are. Mike, would you want to expand on that?
Yeah, I agree. I think we have to define the populations, probably patients with additional mutations, patients with poor response, patients who are failing to achieve TFR. There are niches. The data we have is more about the safe combination of the two. I think we do know we can combine a myristoyl pocket inhibitor and an active site inhibitor, mainly seeing the toxicities of the ATP competitive inhibitors, the classic drugs, kind of shining through, asciminib not adding much. And the doses are different, mind you, between, combination of asciminib with imatinib, asciminib with nilotinib, and asciminib with dasatinib.
Thank you very much, everyone. We could talk all day, but perhaps we should move on to Virginia's second case. And if we have any time at the end, of course, we'll come back for more questions. But Virginia,
So
your
that
second
just-
case, please.
Yeah, just to the end of the patient, she's in sorry, third line with ponatinib, doing well. The response is very, very, very well. Now she's 30 months in treatment, and she's without detection of PCR.
Virginia,
So-
what dose?
I started with 30 milligrams and then lowered to 15.
Very important, I think yeah. So that's a pretty safe dose of ponatinib now, 15 milligrams. That's great outcome.
Wow. Okay, that's it. So this is the second line. The second case is a slightly older, 65-year-old man, hypertension, diabetes, and obesity, a diagnosis, chronic phase, CML, so-called intermediate risk. So we started with dasatinib, 100 milligrams a day, and he had a very, very good response quickly, a complete response, hematological response at a month. 3 months complete cytogenetic response, which I always do bone marrow 3 months. I keep doing it. I'm old, I guess. And at 6 months, my molecular response. So he's doing perfectly well, and he's has a very low. He's doing perfectly well, and at 24 months, he had a pleural effusion. He does not respond with discontinuation. We stop dasatinib for 2 weeks. It got better. Then we restarted at the lower dose. It got worse again. So we decided to change at this time. So we changed to bosutinib. He's doing perfectly well. He was perfectly well he lost a little response because we had to stop the dasatinib for a month, like a month and a half. So he's having bosutinib, and he has a very, very bad tolerance to bosutinib. He had a diarrhea. We tried to adjust the dose. We used the antidiarrheals. We changed the diet, and there was nothing we can do. He didn't tolerate that. He was very, very upset with it. And also he had transaminitis, or even on 200 milligrams. So here we are. So this is the toxicity spectrum of the BCR-ABL inhibitors in adults, and we know that there are common effects to all of them. And then to bosutinib, diarrhea, nausea, and emesis is usually reported, but we usually can manage it. It's weird that you don't manage it, it doesn't get better, but this patient did. So when we try to decide a third line, we try to look at what are the other things. We cannot use nilotinib, of course, in this patient. He's a very high risk for cardiovascular event. Ponatinib, I worry a lot of that because he has all of these comorbidities. So we end up with two options. Sorry about that. We go back to, we think about going back for imatinib, like a lower, and we have to discuss that. We go to imatinib, or we can go to dasatinib. Excuse me, or asciminib we had, but we don't have asciminib. So this is the question, the challenge for this case. Should the transplant be considered at this point for this patient? He's 65. In Latin America, remember, we don't have so many more options. The patient is a good response. TFR is not a goal at diagnosis, but can we go back to imatinib? I mean, going back, we think like a first generation. Asciminib is not available. It's not available in most countries. If asciminib were available, would this patient benefit from a more potent drug? Asciminib versus imatinib, what would you think? Thinking about what I just said, is ponatinib permissive in this setting? Can we use it? Look in this patient, lower the dose, and well, that's the discussion I wanted to have with you.
Okay. Oh, am I on mute? No. Okay, thanks, Virginia. It's another good case. I think, can we just go back to the risk profile for this patient? I think he was diabetic, obese, and
he's hypertensive.
So
diabetes, obesity.
Yeah. So pretty high risk. So I wouldn't contemplate using ponatinib in a patient like this. I mean, he's clearly got very responsive disease. You've got him down at a low level. I mean, he was 0 when he developed his pleural effusion, and has only lost his response because he stopped therapy. So I think he'll respond very nicely to something. I think the best choices would be asciminib or imatinib. Imatinib would probably be perfectly reasonable. I mean, he would probably have more day-to-day toxicity with imatinib, but safe really in terms of his cardiovascular profile. Asciminib has a little bit of a cardiovascular signal. I mean, in the Ask for First study, the rates of events are low for asciminib, but they're about the same as they are for the second generation drugs. And imatinib's had no events. So I think if your main concern at this stage is just to maintain response and absolutely avoid any worsening of his cardiovascular risk, then I would say imatinib's a very good choice. But the downside to imatinib is, as we know, a lot of people do struggle with the day-to-day side effects, and asciminib is much better tolerated on a day-to-day basis. So if you had the luxury of having asciminib, I think that'd be perfectly reasonable. But I think imatinib's a very good choice here as well. What else could you do? I think dasatinib's out of the question now. He's had two pleural effusions, despite lowering the dose. I don't think it's a good choice for him. Bosutinib's out of the question now. And of course, nilotinib and ponatinib are quite inappropriate. So I think that's where your choice lies. And I don't think there's anything wrong at all with using imatinib and still targeting TFR in a few years' time. The thing about imatinib is that once you have a response, it will often maintain that response in these patients. So I'd probably go to imatinib. If he did lose response, then I'll be pushing hard for asciminib.
Okay, great.
And Inez, what would you do?
I think that this patient is very high risk, cardiovascular high risk, and he's not a good candidate for PONA. And what I would do is put him on imatinib. And then I'd wait and see and try to keep that good response and maintain it. I believe that this patient, at least in our setting, is a bit old for a graft. And his cardiovascular comorbidity is also a major factor when making a decision about transplanting. So I would just put in on imatinib. I have a question, actually. I wonder whether this question can be answered later. When we use TKIs at low doses, in our countries, we can't titrate them in blood. So I wonder whether there are studies or guidelines to be able to down titrate and knowing how far without losing efficacy. Because sometimes we are a bit a bit fearsome of going down into subtherapeutic territory, you see.
Yeah, I should have
Mike,
said,
what are your...
sorry, can I just add, I should have said at the start that we probably would have used 50 milligrams daily for this patient. We think in patients with, except for the patients with high risk ELTS where we don't have much data, using 50 milligrams either right at the start or as soon as you've seen that they've achieved a good response, say at 3 months, would be a good option for this patient because they're 65, their risk of pleural effusions is probably 30% or more. We know it's more than 50% in those over 70, but using 50 milligrams greatly reduces that risk. So probably today, if this patient came to our clinic, we'd start him on 50 milligrams. And in terms of your question about dose, we did a very extensive study of dose, and 50 milligrams is perfectly adequate for the vast majority of patients. And if you don't see good response at 3 months, you can easily then increase the dose to 100 milligrams.
Mike, what are your thoughts?
I trying to think what I can add. I think the one comment to make is that this case also represents the nature of pleural toxicity with dasatinib, that it can happen at 2 years of treatment. It's something to be on the constant watch for and have patients educated for breathlessness or symptoms to alert you. And the nature of a severe kind of recalcitrant effusion really is intolerance to the drug. But Tim's comments about the dose and Anna's comments about this case, I mean, this is really a patient who I think can be treated with imatinib. Might have more sort of nuisance toxicities, as I like to call them, but I think the comorbidity index is high. The intolerance to dasatinib is strong. The other drugs are really tough. Asciminib would be a great choice, but we can't rely on that as a choice if it's not available.
Virginia, we'll come back to you, and while you comment, you might also address a question which has come up in the chat. In this clinical case with pleural effusion, were diuretics attempted? Is something like furosemide a good option?
Yeah. Yes, we attempted all, but it didn't work. But I don't know, but usually we use it like in not so massive cases. We also use it, but I have never when the pleural effusion is very massive. It's weird that it works, that the furosemide work. But we use it. We tried it, but it didn't work.
I think it offers very little harm, but very little benefit in these cases.
Yeah.
It's an inflammatory immune driven, not a heart failure, hydrostatic issue.
We sometimes use steroids in this situation, and that can sometimes help. But I guess in most cases, we're probably tending to move on to another drug if we've had a recurrent pleural effusion.
Steroids are more rational given the mechanism of action.
Yes.
And we have a first virtual hand. Diego Reyes Jales, would you like to ask your question?
Hi, everyone. I have a question. When you have adverse reaction, do you use therapeutic drug monitor in this case when there is an adverse reaction related with the drug level?
We never saw that come to clinical fruition to be readily available and broadly available. There certainly is information about drug monitoring, although I don't know if it made a clear story. I think there's data with imatinib, for example, that adverse events may not be necessarily driven by drug level, by quartiles of exposure. I think we see data with dasatinib lower dose studies that adverse events are lower, so that's something. But we're still in the therapeutic index, so I think we're more empiric and go by the clinical data from trials using lower dose or dose reduction once someone's in good response. Some of the data with dose reduction is really quite encouraging, that you can reduce in a patient in good remission or deeper remission, and even probably treat them better and still have a preserved TFR outlook with the Nilo reduction study, the Destiny study, and some other studies.
So to make sure that we don't lose our translator, Sharona, Virginia, can you tie up this case, take down your slides, and we'll move across to Philippe, and then if we have some time at the end, we can come back for some more chat.
Yes, so as we all saw, I changed it to imatinib. He's doing perfectly well. He responded he kept his response and he's doing perfectly well.
Wonderful. Thank you so much. Dr. Felipe López from Chile. Do you have your slides? Hi, Felipe. If you put your slides up, please, and the floor is yours.
Thank you very much. Hey, everyone. I'm going to present a case. This case is a male for 32 years old. He was diagnosed with a CML in chronic phase in August 2019. It was a high-risk patient with so-called HASFOR and ELTS scores. He presented with splenomegaly of 20 centimeters. The blood counts are with a white blood count of 90,000, with blasts of 5%, basophils of 55%, and platelets of 69%. BCR Abel was detected, and it was performed bone marrow flow cytometry with a 4% of myeloblast and 1% of lymphoblast. So dasatinib was started with a dose of 100 milligrams once daily. It achieved complete hematology response, but no molecular response. It was tried for 2 years, and then it was made by Sanger sequencing, Abel1 sequencing with no mutation detected, and then it was moved to nilotinib with a dose of 400 milligrams twice a day. After 7 months of treatment, there was no molecular response with a qPCR of 44% in the international scale. It was then again performed Abel1 sequencing with Sanger with no mutation detected, and a new bone marrow flow cytometry performed with a 9% of myeloblast. Then in May of 2023, it was started with ponatinib. It was delayed due to financial issues that you can see is very common in Latin America. It started with a qPCR of 60% in international scale, but it presents hematology toxicity, so it has to be transient suspended, and the patient progressed to accelerated phase with a bone marrow flow cytometry with a 10.2% of myeloblast and no molecular response with a qPCR of 52%. In this scenario, a patient went into chemotherapy with an induction with a scheme of 7+3 and ponatinib in low dose with a dose of 15 milligrams 3 times a week. After this chemotherapy induction, the bone marrow flow cytometry was with 2.8% of myeloblast. And waiting for the consolidation with bone marrow transplantation, patient experience anger and some EKG ischemic changes, so ponatinib has to be suspended. Patient undergo the bone marrow transplantation with a reduced intense consolidation on May 2024 with an identical related donor. And then 2 months after the bone marrow transplantation, it achieved a molecular response 2 with a 0.21% in the international scale. Ponatinib was resumed with a low dose due to this cardiac adverse event that I just mentioned, and it was requested to initiate asciminib. Patient presented with neutropenia, so it has the change of TKI was made in September of 2024. It initially with 20 milligrams twice a day, and then it was changed to 40 milligrams twice a day for very good tolerance, with a very good response in 2 months after the initiation of the treatment, and so on until the last control in February 2025 with a molecular response of 5 with no detection in the qPCR. So the question, well, there's a graphic with the evolution of the qPCR with the international scale. So our main question will be, what should be the key considerations in terms of security and myelosuppression when choosing a TKI in this scenario of maintenance after bone marrow transplantation? Thank you very much for your attention.
So thanks, Philippe. Yeah, it's an interesting case. It raises a number of interesting issues. The whole issue about TKI therapy post allograft is still kind of not fully resolved, but I think in patients who've got high risk of relapse, we like to use it if at all possible, if the cytopenias allow us to use a TKI. This patient has significant PCR positivity post-transplant, which puts him at a particularly high risk of relapse. So I think it was absolutely right to put him back on ponatinib, even though he has substantial risk of cardiovascular disease. And fortunately, you're able to get hold of asciminib, which is a really good choice in this patient. You've got down to PCR negativity now. And I would think if you can continue the asciminib, that it would be great, certainly for at least 2 years of PCR negativity before I'd even consider stopping it. I don't know whether you have that luxury or not, but I'd be very concerned about stopping it prematurely, because I think his risks of relapse, given his fairly aggressive disease, are fairly high.
Thank you.
Virginia, what are your thoughts?
Well, I think there's not much to add. It's a really difficult situation because you want to use an TKI in this very high risk patient, but it's not always easy to do it after transplant. The toleration is because you also have to have a lot of other meds, and you're gonna have a lot of interactions, so it's not so easy.
Mike.
If I could just add one comment. Yeah, I think it's unknown. You have a post-transplant scenario where you have residual disease. As Tim pointed out, the transcripts were high. That's a higher risk for relapse, but we don't know what that disease is. Is it a chronic phase disease that's left behind after the ponatinib and chemotherapy treated a more aggressive clone? Some might have been impressed with the fact that asciminib did so well when ponatinib wasn't maybe controlling this post-disease, post-transplant, but it might be because we're able to dose it fully, So it's a bit of an empiric application, and I think it was well handled. We have a less familiarity using drugs like asciminib and ponatinib post-transplant, and we look for them because we think the disease might be the same, but the bulk of the data is with imatinib and nilotinib, and at least from studies I'm familiar with from quite a while ago, trying to prevent relapse and maybe preventing relapse of the chronic phase disease underneath, as opposed to the transformed disease, which often leads to transplant.
Ana Inés, we'll give you a chance to comment there as well if our translators are still with us. We've run a little over time. Thanks everyone for hanging in there. Ana Inés?
Right. I agree with the line of action that was taken. This is a patient that we see quite often in Latin America. What is worrisome is that this is a very young person. I think I would have done the exact same thing. I have a question about patients who are transplanted, especially old patients who were transplanted during the chronic phase, and post-transplant they recur and they relapse, and they get imatinib or dasatinib, and they reach complete molecular response for years. I have 2 patients who have been on it for over 8 years on a TKI. Could the TKI be stopped Of course, using monitoring and closely watching the patient, or should we keep these patients, post-transplant patients that had molecular relapse, should be kept long-term? Should they be kept long-term on TKIs?
Yeah, I don't think we really know the answer to that. I mean, if it was chronic phase disease, I'd be more relaxed about stopping after a couple of years. If they'd come into the transplant in blast crisis, I think that's a really hard. If you stop it and they come back with blast crisis, you haven't done them any favors. So if you're at all able to keep going, if they can tolerate it, okay. I tend to keep going in that situation because I don't know the safety. I think some people do stop, but I'm not that confident in that setting.
Yeah,
Thank you. Would anyone like to have closing comments? In that case, I will say thank you very much to Dr. Ana Inés Prado, Dr. Virginia Abello Polo, Professor Mike Morrow, Professor Tim Hughes, Dr. Felipe, thank you very much for joining us with your extra case, and especially to Sharona, our interpreter, who has gone over and above and is going to need to go and lie down for a while. Thank you very much. We have gone a little over time. Thank you for hanging in there. We will see you for the next meeting, next Latin American meeting on the 26th of June. In the meantime, I will circulate invitations. We will have a little post-meeting package present for you in your inbox tomorrow. Thank you very much, everyone. It's been a great discussion as always.